Welcome, everybody. Thank you for joining our research session for the Patient Forum. My name is Nancy Burden. I am the moderator for this session. I'm a longtime kidney patient. It's been 35 years. I've done peritoneal dialysis, transplant, and I'm now on permanent hemodialysis. I'm an avid research partner in many studies. I have a patient and community engagement research certificate, which looks at patient stories and how they can enhance and enrich research materials. I also am a retired occupational therapist and have enjoyed the opportunities of being a part of many people's lives. So with that, let's move on. This session will be discussing two exciting studies that have been funded by the foundation and how the patient input has been central to that research. And now it gives me great pleasure to introduce to you our speakers, Dr. Dylan McKay and Dr. Marie-Chantal Fortin. Dylan lives with type 1 diabetes and is an assistant professor of nutrition and chronic disease at the University of Manitoba. His research focuses on clinical trials and research that is shaped by and engages people with lived experience. Dr. Marie-Chantal Fortin is a transplant nephrologist at the Centre Hospital of Montreal, University of Montreal, a researcher at the Research Centre of the CHUM, a professor at the Faculty of Medicine of the University of Montreal. She received her medical degree from the University of Sherbrooke and completed her nephrology residency at the University of Montreal. She has also completed a PhD in bioethics in 2008 at the University of Montreal. Dr. Fortin is a researcher with the Canadian Donation and Transplant Research and Transplantation, and the co-lead of Research Theme 1. Her research interests are related to transplantation ethics, patient and researcher partnership in research, and clinical care. She is a member of the Ethics Committee of Transplant Quebec, the Canadian Blood Services, and the College of Medicine of Quebec. Finally, she's also a research scholar of the FRQS. Thank you very much for joining us. We will begin with a session with Dr. Dylan McKay and his engagement activities in clinical trials and looking at nutrition in chronic kidney disease. Go ahead, Dr. Dylan.
Thank you for the introduction, Nancy, and for the opportunity to talk about my research. It's something I love to do. Can you all see the slides? Excellent. And you can hear me? Excellent. So yeah, I'm just very honored to be able to present here. I'm a relatively early career researcher, started in 2018, and let me tell you, the pandemic and clinical trials don't go well together, so I couldn't recommend starting during a pandemic. But I'm going to talk about a lot of the engagement activities that I do in my clinical trial work and some of the trials that we have ongoing. And as I mentioned, unfortunately, none of the trials that I have going right now are finished yet because they've been delayed by the pandemic. So just like to start by saying that, I'm located in Winnipeg at the University of Manitoba. And so the lands that I live on are the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples in the homeland of the Métis Nation. And I want to personally acknowledge that, the place where I work and my home the residents in Winnipeg are located on these traditional territories. And, the water I drink comes from Treaty 3. I'm located in Treaty 1. And that I'm, committed in valuing and learning more about the unique richness and diversity of these cultures and, respecting them in the work that I do. And while the University of Manitoba's acknowledgement says that it's in the past, I think there are ongoing harms and things like that are continuing that I think we need to acknowledge. Just to start, I have some disclosures. I have ongoing funding from the Weston Family Foundation, MyTax Canada, PepsiCo, the Northwest Community Health Co-op, Kidney Foundation of Canada, and the Canadian Institutes of Health Research. And I work with some grocery stores, including Save on Foods, with some of the projects that I work in. And to start, I just want to start with some positionality. I'm originally a Newfoundlander. I'm a person who lives with invisible disabilities. I have type 1 diabetes. I'm married to a nurse practitioner, so a clinician. I get that perspective from her every day, and it informs my research a lot. and I'm a father of 2 children. And I'm in the area of nutrition, clinical trials, and nephrology. And unfortunately, if you look at it, nephrology is a field, or kidney research is a field where there are not enough trials. Certainly not enough trials, and that means that the information that we're basing kidney care on is limited because trials and meta-analysis of trials are the best evidence to base recommendations. And so, nephrology trials make up less than 3% of total clinical trials, at least in 2010 they did. And, of those trials, very few of them are actually looking at dietary interventions. So I think there's an opportunity for better trials and better information to inform the recommendations that are in the care for kidney disease. Just to start, basically, what is a clinical trial? I think it outlines interventional research in humans. So, not just looking or observing, but assigning people to interventions and comparing interventions to evaluate their impacts on outcomes. And that's the type of research that I do. Probably the first clinical trial ever dates back to 1747, and Dr. James Lind was looking at treatments for scurvy, and they enrolled, although I'm not sure the consent process at that time, but 12 sailors with scurvy were assigned to different treatments, including nutmeg water, oranges and lemons, salt water, cider, and salt and some dilute acid of some kind. And they quickly learned that the oranges and lemons were the most effective, and that was due to the vitamin C. And actually, they didn't know what vitamin C was at the time, but they sort of figured out a treatment for it, and that's why citrus fruit were always taken around on ships in the later 1700s. And then I guess the other half of it is, what is engagement, right? Or sometimes it's called patient engagement, or patient and public engagement. I just like to call it engagement, but it's the meaningful and active involvement of people with lived experience within the research process. Informing, priority setting, and being involved in the conduct, as well as the analysis of the results and also translating it. And it's that idea that with or by members of a particular population or the public, instead of to or on or about. And this is the type of research that I do. And I have a bias here. Before I was ever a researcher, I was a partner on a project looking at type 1 diabetes, because I guess if I look at that, I'm not just a researcher, I'm a patient every day. And so I believe strongly in engagement in research. And interestingly, one of the big organizations that really sets frameworks and ways to engage populations is called James Lind Alliance, and named after that first clinical trial. And I think it's based on the concept that sometimes researchers might fall in love with questions or methods or ideas or theories that they just want to research, and they don't always necessarily align with what the clinicians or the people being treated, the patients, really want answered. And I think that's an alignment that's incredibly important. And so, you want to address that mismatch by engaging with the populations that you're going to work with to get better research questions and ultimately better results. So what are the key principles of engagement? If people ask me, I always think, it's transparency, inclusivity, supportiveness, mutual respect, and mutual benefit. I think these are the keys that you want to have in engagement research of any kind. You have to be open and transparent with the people that you're engaging and what you're looking for, how they can be involved, and you want to try and include as many people as possible. That want to be involved in the research, but also include them in ways that they set the boundaries for, because there is the potential to overextend individuals by offering them too much, especially with certain chronic disease populations. I know myself with my own condition, there's only so much that I can add sometimes, even if I want to add more. And that means you need to make the environment supportive as well. That's the next thing. And it has to be based on mutual respect and then mutual benefit as well. Individuals with lived experience need to be valued. Their time is valuable. You need to pay them. Their experience is important, and you need to respect their time. And so, people would ask me, well, when do you start engagement in clinical trials? And I think, as early as possible, right at the beginning, before you even come up with the idea for the trial sometimes. That doesn't always happen, but, if you haven't started it yesterday, then start it today, is if another researcher asks me when to do engagement, especially in clinical trials. You can do it even before clinical, but in clinical trials, you should, start right at the beginning. The questions should come, or at least be designed or informed by people who in the population you're looking to treat before you talk to your biostatistician, although they should be really at the beginning as well. And then, co-design the trial if possible. And that's really about maximizing the how good the trials become, and then how valuable the answers and answers can be for the populations you're researching in. Now, how did I start my work in chronic kidney disease? My previous positions as a postdoc, PhD student, it wasn't related to nutrition and chronic disease. It was more specific to clinical trials and nutrition, but I really wanted to return to chronic disease because I have one in that sort of the passionate area to research. Diabetes and chronic kidney disease, of course, is a really serious complication of diabetes in many cases. And I met this nephrologist, colleague, a friend of mine, Dr. Navdeep Tangri. And then I learned that nephrologists really care about nutrition. It's not always true for every specialty, but nephrologists, and especially Dr. Tangri, he was very interested in nutrition and the dietary recommendations, because I think his patients, they talk about food and they talk about the guidelines they have to follow, the recommendations. Registered dietitians are a big part of the kidney care team, and the nephrologists work with them, so they value nutrition. And really, the kidneys are dealing with a lot of the stuff that comes from our diet, so that makes sense. And as a clinician, if you're not a clinician and a researcher, how do you reach patient populations and people with lived experience? And for me, I've just developed partnerships with clinicians because they're there interacting with the population. And we got some funds, very early in 2019, I got some funds to go ask people through a SPORE funded initiative to set up and ask people with chronic kidney disease about nutrition and what interested them. And I'm happy to say it only took a couple of years, but we finally published some of the results of that early engagement. And what we did was we recruited people from one of Dr. Tangri's ongoing trials. And we had focus groups, and we asked them some questions around the dietary recommendations they get related to chronic kidney disease. We looked at the transcripts of those focus groups, and we looked for themes in them. We also asked them some questions about their diet to get some values on their dietary intakes, and we sort of did a mixed methods paper. And I think mixed methods where you have qualitative questions are sometimes very important, because just the hard numbers don't tell you the full story. And a lot of the two main themes from this research that we got is that there was sort of a mismatch and a mistiming in the education around diet and the progression of chronic kidney disease. So that's the idea that often it would be too much information at the wrong times. And then the second one that was very, very big theme that we saw was difficulties adapting to the restrictions. So, I feel this as well as a someone with type 1 diabetes. You feel like you have to follow the diet, and if you don't, you might be cheating on it, and it's very tough to do. And there are barriers around diet and changing our diet that are not personal choice. In fact, I think a lot of our diets are beyond our control. And so when someone says you need to do this, it can sometimes be impossible or feel impossible to follow those restrictions. So, if we're asking people to change their diet and we're asking people to restrict their diet, we really want that to be based on the best possible evidence, because we don't want people to be stressing themselves out and doing so much to change their diet and then actually have no benefit for them. Another thing that we found is that a lot of individuals in this trial reported intakes of potassium that was higher than the recommendations, and that was one of the restrictions they talk about. In some individuals with chronic kidney disease have to restrict potassium, and I'll come back to that in a little bit later. But one of the main ideas that Dr. Tangri talked to me about was metabolic acidosis. So he said quite a few of the people he sees have metabolic acidosis, and essentially in chronic kidney disease, the kidney function declines, and the ability to reduce your daily acid load, excrete the daily acid load, becomes difficult. And so it's estimated that that could impact upwards of 300,000 people in Canada. And the outcomes, chronic kidney disease with metabolic acidosis, it seems to be, predictive of poorer outcomes. So there's a lot of desire to treat metabolic acidosis. Although, unfortunately, we don't have a lot of great options for treating metabolic acidosis. So it's basically the blood is more acidic than you want. And one of the main treatments is sodium bicarbonate or baking soda. And these are a lot of these tablets that you take. And some trials have shown that this sodium bicarbonate treatment are not cost effective, even though it is a very affordable drug. It's baking soda essentially. And data from Manitoba tells us that almost 2/3 of the individuals who get prescribed sodium bicarbonate for metabolic acidosis discontinue. They don't fill the prescriptions anymore. They stop taking it by 1 year. And that's serious because it's associated with faster progression. So we do want to have effective treatments for metabolic acidosis. There is a potential dietary intervention for metabolic acidosis because most of the acid that we intake every day comes from our diet. And there are sources of base that can neutralize that acid in a diet. And that's actually, interestingly, mostly found in fruits and vegetables. So there's been some preliminary work that's looked at giving people fruits and vegetables and having them reduce the net acid contribution to their bodies every day through their diet. And that's one of the interventions we are exploring right now. And this intervention is really from the feedback that patients that Dr. Tangri has seen. They want to know what they can do to help themselves. And they've also told him that the sodium bicarbonate is not working for them, right? They can't take those pills. And so building on some work from Texas, where they did a trial looking at fruits and vegetables, we can calculate almost a dose of bicarbonate equivalent that can be eaten a day. And this is sort of an example. This is what we're going to have people sort of eat every day based on a dose of approximately minus 30 milliequivalent of sodium of bicarbonate, rather than the sodium bicarbonate treatment. And we're exploring this in a clinical trial that I'm hoping to start next month. Actually, we're very close on this one. And previous trials, as I said, have shown that treatment of metabolic acidosis, whether with bicarbonate or whether with fruits and vegetables, can treat the metabolic acidosis, and it can potentially slow the progression. This is a small trial, so it's only about 30 individuals, but it might be able to slow progression of chronic kidney disease as well as metabolic acidosis. And so this is an area that we're looking at. But again, it was in a tightly controlled and rather healthy population from Houston, Texas. And we want to know if it would work in Canada. Different healthcare systems, different patient demographics, different grocery systems, food systems, and so we're testing it in Canada. And we were able to get funding for this trial from CIHR. And as part of that process, we've had people with lived experience of metabolic acidosis and chronic kidney disease every step of the way. So since the beginning, when we started writing the grant and showing up to the meetings and reviewing the materials, and since we've got the disease, since we got the grant, we've actually had individuals reviewing our education material around what the education material for the intervention will be. And so this is just sort of an example of what we're working on: education for how to incorporate the fruits and vegetables into your diet and intervention. We write it up, we work with a dietitian, and then we have someone who has lived experience of metabolic acidosis and chronic kidney disease provide feedback on it. And we're hoping that means that we get a better intervention from that. And we'll see, but I truly believe it will be better. And we've sort of developed a point system to turn the foods into points, and trying to get a certain number of points that are related to sodium bicarbonate in the systems. And in fact, with some of our people with lived experience partners, I submitted for a larger grant on this topic 2 days ago. So cross your fingers for me. This larger trial would actually be across Canada at 14 different renal sites. And part of developing this larger trial's design, we engaged with people with lived experience forums through the Can't Solve SPORE network, as well as people with lived experience of diabetes through the Diabetes Action Canada forum. And we put out the ideas of the trials, we submit the protocols. So the protocol for this trial, we sent it to the Canadian Nephrology Trial Network, the CNTN. And as part of their review, they have someone with lived experience review all of the documents and give feedback on it. And then we make those changes and adapt the documents. And so it's another way that we try to engage with people around the design of the trials. And getting to actually the research that I have that's funded from the chronic kidney disease for the Kidney Foundation of Canada, which I'm very appreciative of, is that before I mentioned potassium, lots of higher than expected or higher than recommended potassium intake in the early engagement work that we did. And one of the things that's in fruits and vegetables is potassium. So actually, while we were trying to get that first trial funded, some of the reviewers immediately said, well, what about all the potassium, right? And that was not just that, other nephrologists were like, what about the potassium? And so when we tried to respond to that, we wanted to see what kind of evidence was the potassium restrictions in chronic kidney disease based on. And unfortunately, they were based on mostly observational data, observational studies where you just follow people, but you don't intervene. And so there was no control of the diet. And we really don't know very much around how much of the circulating serum potassium is due to the potassium you eat, and how much it's related to other things like the current disease state, medications, which we know can strongly influence serum potassium. And so there's really only one trial we could find that looked at 2 different intakes of potassium, and they barely saw a difference in potassium. So we really wanted to increase the evidence for that, because if many people are restricting their dietary potassium and reporting that it's very hard, we want to make sure they're getting benefit for that. So I was very lucky about a year and a half ago, I think, to get funding from the Kidney Foundation of Canada to look at the idea of dietary potassium liberalization in chronic kidney disease. So in this trial, we just started recruiting for it this week. Actually, we're recruiting individuals who have elevated serum potassium, but we're going to monitor whether that's really the diet is influencing it or not. And we're going to do this by delivering the fruits and vegetables that are either high in potassium or low in potassium to individuals' houses for them to eat. And we'll see if that kind of intervention actually changes the serum potassium. And we're very interested in whether it does, because then that'll inform whether we should be making recommendations around potassium in chronic kidney disease. And I just wanted to sort of, say that these were just a couple of the questions that have been co-developed and recommended from our engagement work. And we have other ones that we're really interested in. Basically, every dietary recommendation in chronic kidney disease, we're looking at what the evidence for it is and whether it can be improved on, or whether it's really enough to be making these recommendations. And so there are a lot of questions in nephrology, and I'm really hoping, or my team and I were really hoping to answer a lot of them by having people with lived experience help prioritize and identify those questions, what to look at next, and then helping us design the right trials and the right questions to answer. And then as well as having them involved in the analysis and interpretation. The other thing is finally having them involved in the translation, right? So these types of events where you reach people who live with chronic kidney disease, or nephrologists or dietitians treating people with chronic kidney disease, getting the results back so that they can impact the lives of people living with chronic kidney disease. And I just wanted to end also to say that, obviously research is all about a team. I'm only one small member in it. I really wanted to thank some of the people that have informed our research, particularly Sharon Mosiak and Mary Bocage, who both have helped a lot in our funding and in the application processes and informing our design. And then, individuals like Dr. Karthik Tenankor and Navdeep Kangri, who've been really big mentors to me in this area. And my research lab I share with Dr. Rebecca Mollard. So all of the research I do, it's her and I together, but she lets me do all the presentations because she doesn't really like that very much. So and I guess all the questions are going to go in the second half, so we can move on from here. Back to you, Nancy. I think you're muted still.
My apologies for being muted. Thank you, Dr. McKay. I really appreciate that presentation. And Dr. Marie Chantal Fortin, if you'd like to start, that would be lovely.
Bonjour tout le monde.
Hello, everyone. And I would like to thank, just wait a sec, I'll move things around and I will present my slides. I would like to thank people from the Canadian Kidney Foundation for inviting me to present today. It is a pleasure for me to present how the patient engagement is important in my research. I think this will be a nice complement to what Dylan just presented. I will give this presentation in French, but my slides are in English and I will be able to answer your question in both languages. So here it is. I have no conflict of interest. Now, briefly, this is the outline of my presentation. We'll be talking about patient engagement, 3 examples of research based on the engagement of patients, and then a conclusion. Now, why patient engagement is important, I think Dylan said it well. I'll come back to this just a little bit. First of all, patients who have the right to be involved in research that do concern them, that concern their disease. I am a nephrologist and working in transplantation in Montreal, so I know what treatment is, renal transplanted, but I do not have any idea of what it is to live a daily life with a transplant. And also, there is a democratic argument there. Research in Canada is mainly financed by public funds, depending on the taxes of everyone. So we are all participating to research, and I think the citizens and patients do have their say. And I think that it's been proved that when patients are involved and engaged, it improves the relevancy of the research because Glenn showed it very well. It is encouraging patients recruitment and knowledge transfer. It is taking us to the fields that we did not necessarily think of, and it's also enabling us to take advantage of the patient's expertise. And in the Montreal model, we have disease experts, professionals, experts in research, and we do have people who have an expertise in living with the disease, and they are patients. So this is why it is important to recognize this complementarity and do co-building, co-leadership together, be it in research, but it can also be applied to clinical care and also in health policies. So that's what I'm trying to do in my research. Now, how did I get there? Well, I'm involved in research and donation and transplant to DRP in Canada. And in 2015, the CDTRP existed for 2 years with patients and researchers in order to discuss what should be the topics we were prioritizing within the CDTRP. And so it was, how can we improve communication with families and patients, how we could improve the psychological and social support provided to patients and families, and how we could promote and establish healthy lifestyle habits, and how to increase organ donations. There were 10 of these priorities, and we also compare that with articles published in the 2 important transplant journals in the previous 3 years. And we realized that only 1/4 of these articles were taking into consideration priorities identified by patients, and it was mainly biomedical and clinical topics that were prioritized in this 25% of articles. So we were in 2015 at the time, so patient priorities were not necessarily considered in our research networks. And then, so this was a first exercise we did in 2015 and in 2014, I'm sorry. And in 2015, we decided to go one step further and go with a national survey. And we organized a workshop with patient researchers in order to determine, once again, what were the research priorities. So here on the screen, you see what is of interest to me and what guided my research. We had separated research priorities for post-transplant care and priorities for the organ donation research. So for post-transplant, it was how to improve quality of life of patient, and after an organ donation, how it was possible to increase the number of donors living and deceased, and how to make optimal use of organs. So here I will present three different studies that were strongly influenced by these research priorities, I'm sorry. We've seen one of the priorities was to improve support to families and patients. So in that perspective, with my colleague, Anaïs Cardinal, we wanted to see how I was made that decision to offer or refuse an organ donation from a deceased donor. So we wanted to have the viewpoint of the patients who had received an organ or who were about to receive one. So we organized focus groups. So what came out of these focus groups was that the offer of a kidney is an emotional moment, but it's also a difficult time, and people felt unprepared. Participants were saying that they were trusting the medical team, but wanted to be involved in the decision-making process. Facilitators that were mentioned were support from friends and family, and that sometimes when they had an established relationship with a nephrologist, that would help the decision, and also to get the proper information. Barriers identified were the unexpected nature of the offer, time constraints, because we know that when you're getting a call for a kidney, you do not have a lot of time to make your decision. There is some pressure from the medical teams, and even the medical teams, they're being pressed by the different organ donating organizations, and there's a lack of information and transparency. Patients were mainly a lack of information and transparency to know where they were located on the list of possible recipients, etc. No, they made recommendations in order to improve the process and develop education strategies. Strategies that could be done pre-transplant so that patients know what questions to ask, to know what are the practical aspects of the offer. And these education strategies had to be organized in a special way. And then another recommendation was that nephrologists calling patients should standardize the information provided, because it's not always the case. So this led us to develop to go further. And we now know that patients are not feeling ready. It's a difficult time for them. So with colleague, we wanted to develop educational videos in order to facilitate the decision-making process. We received funding from the Canadian Transplant Society, and we work with two patients, Sylvain Padouin and Marie Bocage, who helped us in this project. And I have Holly Munsell, a pharmacist from Saskatchewan, and other nephrologist colleagues who helped and worked with us on this project. So in the coming weeks or months, we will launch a survey to see what patients would like to get to see in these videos. So be vigilant, and I hope you will participate to that survey. Another project we have developed with Tania Janudis Ferreira is a Keep Active Club. As you've seen earlier, patients were to see an improvement of their quality of life. They also want us to help them maintain a good quality of life. But kidney transplant patients are facing different barriers to be physically active, and that cardiovascular disease is not a priority for transplant patients. So this being said, we have seen in other studies that kidney transplant recipients were highly supportive of peer mentoring programs as a way to gain knowledge on different health issues. So in such a context, my colleague and I decided to create the Keep Active Club. What is a Keep Active Club? Well, that is an intervention that was supposed to be face-to-face, but finally turned out to be an online intervention. You know why? The pandemic. So it was a 6-month online intervention with the support of a kinesiologist, Lloyd, we see here, who's also a transplant patient, and with two patient groups moderated by two patient partners, one in English and one in French, one with Janie and the other one with Lydie. The goal of that project was to assess the feasibility and acceptability. And then during this 6-month intervention, patients were encouraged to exercise. Lloyd was also organizing online exercise sessions. There were different sorts of programs online. So people had a choice. They were not forced to do one type of exercise or another. So here is a qualitative study. It was a small study. It was a pilot project. We had 10 French-speaking patients in the French group and 10 English-speaking patients in the English group. So what came out of that is that people were interested in participating because they wanted to find exercise that would not put their graft at risk, and they would like to return to a more active lifestyle. After 6 months, they reported being in a greater shape, and the peer support was really appreciated. They were communicating via Facebook, and partner patients moderating the Facebook groups were there, but the Facebook platform was not necessarily the most greatly appreciated. Now, we have a new version of the Keep Active Club. So with Danielle, we're trying to see how we could improve it. And finally, the last project I wanted to mention that is also financed by the Canadian Kidney Foundation is the donation, advanced donation program, or with or without voucher. So it had to do with a priority to increase living donor donations. So what is the advanced donation program with the voucher? So the donation, let's say my spouse and my spouse needs a kidney. We're parents of 3 kids. We don't have any social support, so we cannot afford being both at the hospital at the same time. So I may say, as a donor, I want to give now, and in 6 months, when I'll be back to normal health, I want my spouse to receive a kidney, and then I'll be able to take care of the kids and take care of my spouse as well. So this is what we call delayed donation. Now, the voucher delayed donation is something that started in the US because there was this grandfather who had a grandson who came to life with only 1 kidney. And he figured out maybe one day my grandson will need a kidney, but maybe I won't be there. So I'm 65. I am getting old. My grandson doesn't need it right now, but if he does need it in 20, 30 years, I want him to be prioritized. So they go with an exchange program. So he receives a kidney from a living donor. So in the US, they created what they call the voucher donation program. This being said, these advance and voucher donation programs have the potential to increase the number of living donors, may facilitate transplantation. If we increase the number of donors in an exchange program, it could facilitate transplantation of hard to match recipients, people with lots of antibodies, for example. It enables us to overcome chronological incompatibility. This is what I explained earlier. Let's say me and my spouse, this is an hypothetical situation, but that's what happened. And with a voucher gift is kind of an insurance. I may say I don't want to give a kidney to someone I don't know in an exchange program because I have 3 kids, just in case one of them would need a kidney. Now, with the voucher, I could set and give now because I know my kids will be prioritized later on and they have the insurance that will be prioritized. The donor has the freedom to choose the best moment to donate. And for the exchange programs, we figure out that there will be more donors and won't be as many receivers identified with their certificate who will eventually need a kidney. So now, is that an incentive that is morally acceptable? Which kidney will be given for the voucher holder? Who can be listed as a voucher holder? How to prioritize? We can imagine someone from a family where there's a lot of polycystic renal disease, he will give and put on the list as a recipient one of the family members. Now, if 2 family members need a kidney at the same time, how do we prioritize them? How to make sure that we have a good consent, and is it just for other patients? Is there any equity? So I decided to launch a research project financed by the Canadian Kidney Foundation to gather kidney transplant recipients, transplant candidates, living donors' perspective, and also health professionals on this type of donation. So we decided to do qualitative interviews for that. So now I'm just giving you the patient's perspectives today. So what we've seen from these interviews is that patients are kind of open-minded. They're open to that type of donation because it's reduced the waiting list. Now, there are ethical issues and equity issue. Is it fair for patients who are not voucher holders? And the idea of informed consent, when we get in such a project of a voucher with or without or delayed donation with or without a voucher, we don't know if the beneficiary will need a kidney. How will this happen in the future? How is it possible to get informed consent? There are uncertainties for the future. Now, logistical issues, the number of voucher holders in the US, there are 5 vouchers for each donor. Once the voucher is used, that's it. I mean, it's over. No other beneficiary can benefit from the kidney. Now, will these vouchers be transferable? Let's say I'm a donor in that program with an advanced donation without a voucher exchange, and my spouse and my kids are registered, but in 10 years from now, I'm not with my spouse anymore. Is that voucher transferable to someone else? And all the uncertainties what will happen if voucher programs, at the moment they're administered by the Blood Society here in Canada, but what will happen if they do not exist anymore in the future? Will the vouchers be valid over time? Now, next steps, we're working on a national-based survey to gather more opinions on the subject. And then we're also working with the Canadian Blood Society. They want to develop a program of advanced and with or without voucher. So I hope that with my presentation, I was able to show you that patients' input and knowledge have a great influence on the research topics and the design of the studies. You have an important and valuable experiential knowledge that will help us in our research projects. And now a little bit of advertisement for my research network. If you want to get involved as a partner patient within the national program in donation and transplantation, you may contact Manuel Escoto, and he will be pleased to support you and help you in this. As Dylan already mentioned, research is not something you do on your own. You're not alone. So I would like to thank Fabien, Françoise, Elia, Karina, Savannah, my research team, and also all the organizations supporting me in my research. So thank you for your attention, and I will be pleased to answer your questions.
Thank you, Dr. Fortin. All right, so the questions and answers are open. I see we've got, let's see, we've got one question for sure. If you want to check it, Dr. Fortin, you might want to have a read. Dylan, if you'd like to chime in on this one, that's okay too.
Well, they were working with pigs for transplant donors. They have solved the problem with the pigs. Why this is not being used on patients? The US is farther ahead than Canadian healthcare. I would have rather gone this route. This is a very good question. Well, xenotransplantation is still at the beginning. Of course, we had highly publicized cases last year of a xenotransplant, but when we read the article, it's still not there. They are working to have, really compatible kidneys, and so I think it's the future, but we are still not there. And we are looking at the research that is performed in the US. So Sue Bevington, I don't see her question.
No.
And the email of Manuel Escoto, yes, I could, maybe we could put it on the chat. I could put the email of Manuel.
Okay, thank you for that. Do we have any other questions? Oh, no, haven't seen any extras. I'd like to thank you both. We're not done. I just wanted to let you know how much I appreciate your perspective as a both as a patient partner and one who's advocating so hard for it. It sounds like you've both had some really strong experiences and some great opportunities, and you've created them to make them happen. So it's really exciting for me to see that, and I hope that that's going to take us in new directions. So it looks like we've got a comment.
Okay, there's one in French. Je suis présentement sur la liste de Transplant Québec en attente d'une greffe de rein.
Quebec transplant, do you think I will have access soon to this videos? They're not ready yet. We're just at the preliminary steps. Mais restez à l'affût.
Un an ou deux, une fois qu'on aura...
In 1 or 2 years, when we'll be done with the videos, we'll definitely market them, let you know, and we'll definitely use the Canadian Kidney Foundation and other organizations to talk about them.
Okay, thank you. We also see a question for the
Miss,
foundation, although it might be a good question for discussion for both Dr. Fortin and Dr. McKay about the opt-out system for organ donation. So rather than agreeing to do it, you have to say you don't want to do it. Would either of you like to comment on that?
I can. There is currently research on opt-out with the CDTRP. I know there's a leader study which are looking at all the aspects of what's going on in Nova Scotia, and I think Alberta also turned with opt-out, if I'm correct. And so we'll have to see what's going on with the opt-out. I think this is a hot topic in organ donation research. And but just a comment, you know, opt-out is not working if you don't do, you know, public awareness campaign to be sure that people are aware of their options. And so most of the time when they implement opt-out, as in the UK, it was with a really big public awareness campaign to. So what is really the cause of increasing organ donation? Is it all the public awareness, or it's really opt-out? So I think, but this is a good question. It is a hot topic, and my colleague Matt Weiss is conducting research on that topic with a big team of research.
Yeah, absolutely. Dr. McKay, did you want to comment on that at all?
Well, you know, those would only be my personal opinions on it. I don't research ethics per se and transplantation. So I do see a question here related to caregivers, and
Yep.
that was on one of my slides. So
Perfect.
yeah, a lot of the research, you know, the focus groups that we did were of individuals with lived experience or caregivers as well, falling in that category. You know, very interested in their experience, and especially in the interventions that I provide, you know, which we're always trying to be like literally deliver food to people's houses. Is the intervention for the most part in the two trials that I talked about. But interestingly, in the metabolic acidosis research that we're doing, one of the early results from Texas in Texas was that the intervention didn't start working until they delivered enough food for every member of the family, not just the person with metabolic acidosis. And when they asked people afterwards, it was because of sharing, right? You couldn't just deliver a little bit of food. People in the households would share the food. It'd go into the entire food budget. So our interventions are based on everybody in the family would get their dose of fruits and vegetables. But when we do focus groups, we ask the caregivers, because in many cases, individuals may be having other people assist them in you know, in their grocery shopping, in preparing their meals. And you know, the caregivers for individuals with chronic disease take on a lot of the care, extra care burden, and so I think it's very important to include them whenever possible.
Agreed. Yeah, because it's certainly not just the patient that's the focus of living and recovering and living well with kidney disease, whether you're on dialysis or not. Dr. Fortin, you'd like to answer the question on participation?
Well, I'm just typing that if there are patients who want to participate in research project, you can go on the cdtrp.ca. You can also check on the Facebook page of the Kidney Foundation about sometimes they advertise many research projects. Well, I use the Facebook, thanks to the Kidney Foundation for their support, but I use their social media to advertise my research project. So you can contact me if you want. You can talk with your transplant at your transplant center. I'm sure there are some research projects. So there are many ways to get involved. Well, I'm talking about the CDTRP, but of course you can be involved with CanSolve CKD. So, well, so I'm not in competition with CanSolve, but it's only because I'm really involved from the beginning with the CDTRP. So yeah,
Yeah.
many ways to participate, and thank you for your support, and thanks to the patients, because, well, for myself, and I'm sure it's the same thing for Dylan, that we wouldn't be successful at conducting research if there were no patients who participate in our research. And also, if we didn't have your input, that would have been so different. So yeah, thank you.
Well, and I can say as a patient partner and a patient researcher that the opportunity not only to meet some really amazing people, but the learning opportunities about research and how complicated and challenging it can be, and how rewarding it is to be a part of that, to see your ideas and your concepts grow and expand to become a part of the research as opposed to a sideline or a checkbox. And it is, I speak from experience that I've thoroughly enjoyed being a patient partner in research, that, and I've seen it go from being, yep, that's a good idea, to, well, let's talk about that. I've got some other suggestions, or so it becomes a true discussion versus the researchers doing it with us rather than truly being a part of it.
And can I add something,
Sure.
Nancy? If also, I just want to add, I'm a clinician scientist, so I'm doing research. I have two hats, one clinician and one researcher, but working with patient partner also changed the way I am as a clinician. It opened me to other reality that I was not aware, because, well, when you meet your patient at the clinic, your patient, you're focusing on creatinine and tacrolimus and things like that, and you're not necessarily sharing with your patient about their lives. And it's really when I partner with patients that I realize many complex issues that you are experiencing. So thank you. Well, maybe it's only me because I'm a crazy person, but it really helped me, I think, to be a better clinician.
Oh, that's wonderful. Okay, thank you for that. We do have another question about, do either one of you know the status of the artificial kidney? Stanford University, is it? There's a number of, I think as a long-term patient, I've seen lots of artificial kidneys come out. Is there any status out there? Do we have some progression in the artificial kidney beyond the dialysis machine, which is essentially an artificial kidney?
This is a good question. I don't have the answer. So it's really outside of my field of expertise.
Yeah. Same with you, Dr. McKay?
Even more outside of the field of my expertise, yeah. I mean, I can't, I mean, just to follow up, I think I'm not a clinician, so, but involvement as a patient partner and clinicians who do work with patient partners, when you visit them as a patient, you can see a difference, I think. And so I've had, I think the more the better. And I know that every clinician can't be a clinician researcher, but the involvement and seeing the impact of the whole life, and then not just being a number, or some values that I know are very important and have to be monitored, but those numbers don't always matter as much to the patient as the clinician.
Well, and we are seeing some very strong direction towards bringing quantitative and qualitative, so numerical and patient experience together, so that we really do see a clearer understanding of what those numbers actually mean, which is where I think that intersection and blending has been so valuable, that when you understand what your numbers mean, then not only are they easier to transfer, because then you're telling people, they're going, oh, that makes sense to me, versus a percentage doesn't often necessarily mean anything. So I think that we're seeing some super improvement that way as well, which I think will hopefully educate our patient partners and our family members and other clinicians about what's happening in research and where it's going, because it still tends to be sort of an isolated pot that, we've got researchers, but where are they? They're sort of hiding, hence the questions as to where to find things. Oh, okay, belt designs on dialysis units. Yeah, this looks familiar. Again, it's sort of outside this discussion point, but I can tell you that it's been around for about at least 11 or 12 years or more. And the idea was a wearable dialysis unit, essentially, like a dialysis machine. I don't think there's been much progress, but I can't tell you that for sure. So artificial kidneys are still somewhat distant from what I've heard. And I'm speaking only by my opinion. That's not evidence-based at all. Is there anything else? Have we got more questions? Any comments? How do you feel about the information you learned? Is it something that, again, we've got people that are interested, that's fantastic. How do you feel about the research? Is it something that you see as bringing, for instance, the comment about having vouchers and future donation is a little mind-blowing when you think about it. Pretty exciting for those that might need it. And we've got another, okay. So yes, I think so these are bringing in new ideas, again, being advanced, what's out there, what's happening, what's new. And Dr. McKay, the concept and the importance of really understanding the kidney diet, speaking as one who's lived on it for, feels like forever, is exciting. That giving us some evidence to work on, I think is a pretty amazing opportunity. And so thank you for that.
One of the things I guess I didn't hit on in the presentation, just the design, but the general concept of the research that I've been working with Dr. Tangri and others is ideas that, you know, maybe with certain chronic disease types, you just get food delivered to your house as part of the treatment. You know, I didn't mention it, but a lot of the metabolic acidosis work, we're doing health economic evaluations, because
Yes.
one of the big feedbacks we got on, you know, the first thing we do is we get an idea and then we go ask for money, and then people say all kinds of things
Yes,
about it, right?
yeah.
That's
The
the
process.
process. And then we respond to that, and we have our partners and everyone works to fix that. And so one of the big things we got as well, you know, what's the sustainability? This is just too expensive. You know, you think about affordability, et cetera, barriers to fruit and vegetables in Canada and in communities. And so I'm actually partnering with a grocery store and things like that. We're capturing the costs, and we're going to estimate, because when a new drug comes out for, say, metabolic acidosis, and one recently just failed, but it was estimated to be coming out at quite a high price tag, something probably like around $12,000 a year for a course of the medication. And of course, it's going to be priced that high because when we delay the onset of dialysis, you're hopefully improving quality of life, but also reducing costs to the healthcare system. And then drug companies use that formula and say, this is how much we're going to charge. And if it does that, then the healthcare system in Canada says, yes, definitely, great, we'll cover the drug, or not, depending on it. And so when you think about that, we think we could have groceries delivered to somebody, enough for the whole family, at around $3,000, $4,000 a year. But that's just seems like crazy when we go to some reviewers, and then you say, well, the drugs were going to be coming in at $12,000 a year, and we say, okay, that makes sense. So we want to develop the same kind of evidence, you know, the same type of health care economic modeling to show that if we deliver the foods, if we get the same outcomes. We want provincial plans to start covering these things, and so that's the long-term dreams and goals of the research program we're in.
Well, and we've had a cheer for you in the box from Janet.
Thanks, Janet.
I know when we look at another perspective for those that literally can't afford the food and are eating in places that they can't afford, which is 98% of the time fast food and certainly not on the menu for them. What an opportunity. And we look at the really big picture. Now we're looking at really good healthcare management, that rather than them, again, utilizing more medical dollars, are now healthier, in a better place, and actually presumably a better quality of life as well. So it's certainly much broader than the dollar. And I don't think it's without possibility at all when you look at the really big picture. So yeah.
Well, the pandemic told us that home delivery of groceries has pretty far reaches. That, you know, they can be designed, it can be done. So it's not out of the realm of possible yet.
Absolutely, absolutely. So we have another question about participation. Is that, do we want to address that again? It's in the Q&A.
Well, it's not the same question as before?
Is it? Oh, 320, yeah. You know what's happened? Yeah, you're right. You're right. Sorry about that. So yeah, when we look at research in general, and I think this is where research has really changed, is that looking at implementation. What are we going to do with it? How can we make it a reality, especially now that we have the evidence to support it? Or how can we modify it if it doesn't? And that whole blend of ideas, research, make sure that it is what we think it is, and that blend of patient partnership to make it applicable and impact related really has some strong possibilities to, again, make reality, or not reality, but make research more of a reality for people that are living with the disease. Okay, where do you find information on studies? Are there any in Manitoba is another question that's out there.
So the trials that I was I'm based in Manitoba, so most of the trials that I'm involved with are recruiting from Seven Oaks Hospital. We have some trials that are going to be at Seven Oaks Health Science, and we're hoping to expand some of them to all of the 3 major renal units in Manitoba right now. But that requires funding and all kinds of other logistics. So it's unfortunately a very, it's a slow and steady process to get from the idea to the funding to the recruiting. And so most of the trials are going to be recruited from existing populations, clinics, rather than advertised for the general population, because the logistics for getting the individuals into the trial and knowing what the criteria are. So none of the trials that I'm doing right now have sort of open enrollment. It's through clinics
Okay.
in Manitoba right now.
Okay, is there, I'm wondering too about, so we've got ongoing studies. So how do we find out about the completed studies? Where do we find the information that the study's done? And this is the information that was gleaned, and potentially, where does it go from here? Is that available? Is there something out there?
I mean, there is a registry of clinical trials in North America. It's not necessarily the most user-friendly, but you can actually search it by location, and you can look at past and present. You can search it by disease type and topic and things like that. I have to register every in trial. You can actually look me up and see every single trial that I have and where it is, and past ones and the future ones and the planned ones. It's clinicaltrials.gov. I'll write it in the chat here.
Okay,
But
great.
Mary, do you have another idea there?
No. I totally agree with you.
Okay, I have a related question. And this is partly coming from my experience. So how did the both of you learn and embrace working with patient partners? Where did that knowledge come from?
This is a really good question. Well, I think it starts from my bioethics degree, where I think the patient voice were really important also to take into consideration, and also all the narrative ethics that looks at patient stories. And also I was at the university, they were pioneering the patient partnership. So it's all that brought me to embrace patient partnership in research and in clinical activities too.
Excellent. Okay.
For me, it was probably when I was 13. I actually diagnosed myself with type 1 diabetes. So I was a patient long before a researcher. But seriously, my beyond that, when I was in undergraduate, or actually in my master's degree, I saw an advertisement for someone recruiting patient partners to a research program that I joined related to exercise and type 1 diabetes. And then my first independent position was actually at a CIHR SPORE support unit. So these are these provincial platforms that are facilitating services surrounding patient engagement in research and health research. And so when you're working there supporting people to do it, you really you buy into it. But I'd already been really seeing the benefit of it. And then personally, one experience, somebody wanted to help me design a trial, And we had a bunch of people who would help design the intervention. And I actually did a thing where I came up with what I thought the main outcomes in the trial should be. And then I met a bunch of people who had gone through the program and compared the list of outcomes, and all of mine were wrong. And so I just threw my list away and realized that I was going to completely design the wrong trial. And it was sort of like one of those, learn by failing moments where because I had never been in the intervention and it wasn't necessarily designed for me. I just had the methodology on trials, and without that, I totally missed. And so it was a hard lesson, but a good lesson to learn.
And you learned well. Good for you. Okay. Do we have any more questions, any more thoughts or ideas on information that we've shared? Hopefully we've inspired people to look into research, see what's out there, to think about becoming a patient partner. The good news about that, and what many patient partners may not know, is that you can go from, and this will just take me a moment, you can go from doing reviewing and editing to being a full-blown patient or patient researcher. And with that, I've just been cued that it's time to wrap it up. So first of all, a huge thank you to both of you for sharing your studies. Really interesting, lots of good information. Equally exciting is your involvement and your passion about involving patient partners. So thank you again. I really appreciate the time you've taken to be with us and the work you put into it.